Good afternoon. I'm Ann Greiner, President and CEO of the Primary Care Collaborative, and I am so excited about this webinar today. What do patients want from primary care both during and after COVID-19? We have an incredible set of panelists, and I will introduce them shortly. But first, if you're not acquainted with the PCC, the Patient-Centered previously the Patient-Centered Primary Care Collaborative, now the Primary Care Collaborative, let me just take a minute to acquaint you. We are a multi-stakeholder organization that advocates for more robust, more patient-centered primary care. We have 60 plus organizations that are a part of our membership. If you are not a PCC member, we invite you to join us, and please get in touch and we'll tell you all about our work to advance primary care. A critical part of our mission is understanding what patients' needs and preferences are, and so I'm very pleased today to host this webinar that brings together patient experts who have worked to really discern what patients are looking for through a series of focus groups and also a regular survey. And they will be reflecting on what patients want and give us some advice about how we can move our system forward to be more responsive to what patients are asking for in terms of primary care. A couple of housekeeping things, just so you know, all of your lines are going to be muted because we have hundreds and hundreds of people on this webinar today. And while we'd love to talk to all of you, it's just not possible. So hundreds of people actually sent their questions in advance, but we also ask you to chat them into the chat feature, and we have reserved time at the end of the presentations to answer those questions. We are also very pleased to welcome a partner, the Green Center, and the Green Center is co-directed by Rebecca Etz. She is truly an unusual researcher in that she is focused on really trying to understand things in real time and be responsive to the policy environment. And so they are a great partner for the PCC. We've been working over the last number of months, really since COVID struck, to partner with them on a survey that they have been doing of primary care clinicians and of primary care patients. So we'll hear from them. Let me introduce our speakers. Anne Huang, who is a doctor and an internist, I believe, is the director of the Center for Consumer Engagement and Health Innovation at Community Catalyst. And in that role, she leads the center in bringing the consumer experience to the forefront of health system transformation efforts. She's also a practicing physician. She is in clinic on Thursdays, we learned earlier today, and she's a health policy expert. So she brings both the clinician perspective and the policy expertise to this conversation. Rebecca, who I introduced previously, is a cultural anthropologist. And so she really understands a lot about the different medical tribes and nursing tribes within healthcare, and helps us to, bring, she brings a unique understanding and perspective to helping us figure out what's going on in our health system. She's at Virginia Commonwealth University, and she has expertise in quality research methods and design, primary care measures, practice transformation, and also in how to engage stakeholders. She, as I mentioned earlier, has been fielding this survey regularly about primary care primary care practices during COVID-19. Linda Flowers, hello Linda, is from AARP, where she is a senior policy advisor. She is a nurse. She has her master's in nursing and also a JD, and she's part of the Institute's health security team, which conducts research and policy analysis, brings together thought leaders to develop and advance AARP's public policy agenda on healthcare, and I know she has particular expertise in Medicaid. She's very focused on access to healthcare services, quality and safety, cost of care, and public health. And so I think we are really in for a treat. Anne will go first, followed by Rebecca, and then Linda will have a chance to really reflect on the findings from their focus group reports and the survey. Let me hand this over to Anne Huang.
Great. Thank you so much for the invitation to be here today. I get to talk about something near and dear to my heart, which is what patients want from primary care. And as Anne Greiner noted, I'm a primary care physician. In my role at the center, we're very interested in how policy change and practice change can be strongly informed by the voices of consumers, the patients, families, and caregivers. And we're particularly focused on people who have the most complex health and social needs. So we conducted, let me see if I hope someone didn't steal the controls back from me. I'm trying to move the slides along. Okay, good. So we did some focus groups in the fall of 2019. So they were done before there was such a thing known as COVID, and it feels like a lifetime ago. We were very interested in understanding the experience of individuals, particularly individuals from low-income communities and also people of color, with primary care. And we were probing, especially in terms of the interplay between social determinants of health and primary care. These focus groups were conducted by Opinion Works for us, and we conducted them in 4 different states, and we worked to ensure that we were conducting them in rural, suburban, and urban communities. We included several Spanish language groups, and they were professionally facilitated by facilitators from Opinion Works who had the ability to really connect with the individuals that they were speaking with. The findings, we wanted to share a couple things in terms of the context. One, as I mentioned, we were interested in individuals who had complex health and social needs, and I think the conversations confirmed that the people we were speaking with were facing extreme social and financial stress. They described challenges with transportation, food, and housing, challenging personal relationships, the concern about losing children and family separation. And there were lots of themes around loneliness and isolation, particularly among older adults. The other piece about context was that when we asked them to talk about their experiences about the health system, there was a significant sense of disappointment and cynicism. The sense that healthcare was a business, that patients were on a conveyor belt, and in one of the very memorable quotes, like a conveyor belt where they're milking the cows. And when it came to talk about social determinants, there was some concern, well, you can't even, you're lucky if you get the problem that you went in there for addressed, much less if providers are starting to talk about food and health and everything else. They don't have time for that. That said, we actually felt that there was a very hopeful conversation that happened in many of these groups. It really was a validation that people value a relationship with the primary care provider. They want someone who is able to take time to listen, to get to know them, and they want a relationship over time. So in our report, we developed and described 5 consumer aspirations for the primary care system. I'm just going to speak to a couple of them today, given limitations on time, but I did include a link to the full report. And I'm just going to touch on a couple themes that I think are important and continue to be very relevant as we think about life during and after COVID-19. The first thing is just the importance of the primary care relationship. People want to be known, and they want to be able to see the same provider over time. And one of the quotes here that I love is that you have to act like you care. And this participant noted that it's crazy that Walmart has training, but a place like a doctor's office wouldn't have that same kind of training in order to interact with people in an empathic and caring way. There was a sense of the healthcare system as being incredibly complex and a need and a desire to have someone who was on their side to help navigate the healthcare system. There was interest in welcoming a broader conversation. I know sometimes as a provider, I think, do people really want to talk to me about what's happening in their lives? And the answer is yes, but it is important who is asking, how you're asking, and why you're asking. And one participant said, you know, if you really care about me and I get to see you regularly, then yeah, I don't mind telling you things. But if I'm just going to see you, you know, very intermittently, why do I need to tell you all this for? And another place where this came up is people had a lot of suspicion around questions when they didn't know why they're being asked. And the example was around a common question, which is, are there guns in the home? And some of the participants in the focus group said, why do you need to know that? And so understanding who's asking, how you're asking, and why you're asking is really important. There was interest in having co-location of services and this idea of a one-stop shop. And the final area that I'll just very briefly touch on is this ability to relate. And it's language and cultural affinity. There were some interesting findings around gender, specifically women preferring a female provider. But there was also this desire to have someone who understood their life experiences. So this quote came, they wanted someone who understood, who had had financial hardship, that they felt more comfortable talking to someone who had been in their shoes. So I'm just going to sum up by reflecting broadly. You know, the first thing to me that I found really kind of heartbreaking is that, you know, if you think as a provider that the stress that you feel being on the conveyor belt and being on a treadmill and being on a 15-minute clock, if you're, you know, insulating your patients from that, you're not. They know, they see that as well, and nobody likes that. And I think when we think about what's needed from a policy perspective, there's two questions I've teed up here. One is people want continuity and they want relationship-based care. We don't particularly incentivize or pay for that. So how do we start thinking about how do we encourage that and reward that across the system? And then the last question is, how do we build trust? You know, whether that's individual providers taking that kind of Walmart empathy training, or whether it's thinking about expanding the healthcare team to include people from the community who are able to relate to the patients that they're caring for. So with that, I'm just going to end there. I've included a couple resources. This is the link to the report and a few other things that will be in my slides.
Thank you so much, Anne. And we will make sure that we also include those links in the materials that we send out. Rebecca.
Thanks. Tough act to follow, Anne, so hopefully I'll do okay. Anne Greiner introduced me. I'm Rebecca Etz from the Larry Green Center. We are a virtual center sort of co-located in Richmond, Virginia and Cleveland, Ohio. So you can imagine we've gotten very used to video conferences over the past few years. All of the work I'm going to present is a skimming off the top of a survey that we have been running since March 13th, when the national emergency was declared. I put this up here just so you can see. We have a large number of folks that we have heard from. We make these surveys short so that they don't provide too much of a burden to people responding to them. We really don't believe in getting all the information you can. We try only to ask for that which we are going to be able to make use of for the benefit of the people providing it. So that's a hard stop line for us. Our partnership with the Primary Care Collaborative has been absolutely indispensable, as has our partnership with the Third Conversation, in which we get a real investment in patient voice as well as clinician voice. I also like to call out the funders, the Morris Singer Foundation and the Samueli Foundation, because without them, we wouldn't be able to be continuing right now. And this is critical work. There's no other data set out there quite like this. So the first thing, everybody here knows what primary care is. You're used to seeing the 4 tenets of primary care as proposed by Barbara Starfield that I have on the bottom. I don't know if we're always used to thinking of it as a social contract. So I'm an anthropologist, but I often speak as if I'm part of primary care because I feel it. And the social contract that we have is that we will be worthy of your trust. It's safe to be invulnerable in front of us, and we will contemplate and grant the wholeness of your dignity. We put patient interest first above our own. And part of that contract is then that society invests in this basic good. And that's the idea. We put ourselves first, and in exchange, society supports this basic social good. So as we looked at what's happened, I want to remind you that we are a country of 320 million plus, that healthcare is the 4th largest industry, and that primary care is its largest platform. This is a huge, huge industry that we're talking about. And within 14 days, it entirely changed how it delivered care, from face-to-face, majority face-to-face visits to majority telehealth visits. They did that without any investment in the infrastructure and without any plan for payment or reimbursement of services. They put patients first, as is our social contract. 2/3 of them reported on doing positive outreach to patients, just calling them to see if they're okay during the pandemic or to follow up with them if they were isolating at home. At the same time that they were doing all of this work, they were experiencing an 85% drop off in face-to-face visits, which is how they get their income. They were being paid for less than half the work they were doing, but they were working extra hours, and they were needing to furlough almost half of their staff in order to maintain their doors as open. So there was a significant investment going on here. The first thing then we want to know is, was primary care actually happening from the start of COVID through to now? And the answer is yes, and it's yes in spades from both the patients and the clinicians. So here are the 4 tenets that we talked about. The blue bar is what patients say, and the orange bar is what clinicians say. And you can see they're pretty parallel. The majority of them say across the board that these things, even during COVID, have remained present for them. And the 2 short bars are the small people who respond at the very negative end of the scale, saying, no, this hasn't happened for me at all. Again, great alignment between the experience of clinicians and patients. They also both say relationships are the foundation of our discipline. And the foundation of where healing happens. Patients often talk about it as being grounded, that they actually give, relationships give a sense of connection to the healer who has their best interest at heart. Clinicians say, this is what I do. We do personalized, relationship-based, integrated, equitable, and compassionate care. That is our mission. So during COVID, what has that relationship yielded? Well, patients have been quite eloquent in saying what it's yielded. They say it means I have somebody I can trust, just like Anne was speaking about. They say it means I feel connected. I can ask about anything, medical or not, and they help me make sense of things. And we all know this to be true. Anybody who has a parent and called them when they're sick knows that witnessing all by itself incurs healing. And many patients say, it just makes me feel better when I get to see them or talk to them. So what does that mean? And what does it mean to actually take into account medical or not? Well, we had a very sad and clear example of what treating people as whole people can mean when George Floyd was killed. So we asked both patients and practices, what did this look like? Not all of the formatting is a little off here on the screen, so I can tell you what some of these are. The top bars relate to patients. The first one was over 80% of patients saying that racism absolutely affects their health. I want you to understand that 30% of this sample was minority. And I'm not saying that because I want to tell you how large the minority sample is. I'm saying that because I want you to understand the population as a whole understands this basic point. Racism affects health of everyone. The next bar down is about, did they actually seek care from primary care for racism after George Floyd was killed? And the answer was actually yes. And some, the smallest bar, called primary care because they were just generally upset. They couldn't identify why, and they wanted somebody to talk to. These are their trusted relationships. So this is where they go for healing for somebody to make sense for them. The orange bars relate to what happened from the clinician perspectives, and going down the 4 bars, what they said was, yes, we had patients who came in who had no discernible reason that they could present, but it was related to current events and the structural upset that we were experiencing in our society. The bottom line is actually the number of clinicians who said this affected their minority patients more than others. The line one up for that is the number of clinicians who said physical symptoms were present from the experience of structural racism. This is what it means to have a relationship, to deal with patients and what their needs are and their goals. It was really quite moving. The second thing that I wanted to point out is that there's a second public health crisis brewing, and you all know it. We're really worried about what this is going to mean, and it has to do with patients holding back, being nervous about going to see the doctor because they're nervous about going out, or they're nervous about what's going to happen in the practice when they get there. They are overdue for many services and avoiding the practice even when they're sick or injured. Clinicians are worried about this too, and they've really noticed the result. When people do come in, over 80% of them have intense emotional and mental distress related with their condition. Their health issues have gotten worse. There are more complaints per visit, and those visits have greater complexity to them. There are a third of practices have experienced patients' deaths, and here I want you to think about relationship is a two-way street. This means that a third of clinicians who have relationships, long-standing relationships with their patients, have lost these people to COVID. In addition to that, they have watched people die, not from COVID, but from COVID-related constraints of access to care, whether it's payment or specialty practices closing or hospitals not able to take on patients during the surge. This is a very important point. So what do we think can help with that? Well, actually, telehealth can help a lot. Telehealth can help a lot. And I'm going to go through this quickly because I want to leave time for our interaction and to hear from Linda. I'm really looking forward to that. But telehealth can help, and patients are dealing with a tremendous amount of social isolation and depression. Clinicians say, look, we agree. Telehealth isn't the end all be all. It has limitations, but you know what? It's really good for counseling. It's really good for building on those relationships and banking on them to help with somebody's health. And it turns out at just the time we need it, insurers are starting to pull out. 20% of practices have seen insurers pull back on their support of telehealth. And as a result, a third of practices have started to reduce their use of telehealth and phone payment. So that's mostly what I have. And I just leave it with a question. What happened to the social contract? Here we had a large group of people. They handle 500 million visits a year. They do it with a third of the workforce and 7% of the spend. And at the time when they flipped on a dime, we pulled back on our support. I'm really hoping it's something we can fix, because the one contract that hasn't broken, which is clear, is that between patients and clinicians. Thanks.
Thank you so much, Becca. And now we're really interested in Linda's reaction to these two fabulous presentations.
So just picking up where I left off, just wanted to say thank you to Ann and Rebecca for doing this work. It's really important work, and I'm eager to share it with colleagues. I think it can help us think about how we can push forward. Just wanted to say again that my name is Linda Flowers, and I'm with the AARP Public Policy Institute. With our nearly 38 million members in all 50 states, DC, and the US territories, we are a nonpartisan, nonprofit, nationwide organization that helps people live their best lives as they age. So with that, I'd like to turn to addressing some of the points that Ann and Rebecca made. And as I thought about it and took a step back, I sort of thought of it in terms of we either have a perfect storm or a perfect opportunity in terms of what's going on in our environment currently. So when I thought about that, I identified 4 environmental influences that I think are going to be very important for primary care to address. The first is that consumers want providers to address the whole person, and they particularly want them to address the social determinants of health, but predicated on a trust relationship. So that puts a lot of emphasis on how do we build trust between providers and the consumers they work with. The other thing that I took away from the survey is that primary care providers, from the Green survey, is that it highlights how providers are facing unprecedented stress as they weather the storm, and many may not make it through as we continue to face this pandemic. Then on a societal level, as Rebecca talked about, we're seeing the pandemic has forced us to come face to face with the extreme racial and ethnic health disparities that are largely driven by structural racism that undergirds the social determinants of health. So the confluence of these disparate impacts of COVID-19 on people of color, coupled with the horrific murder of George Floyd, have put disparities in the structural racism that drives them clearly in the spotlight. Then the fourth factor that I think is influencing is the aging of the population. With the number of Americans aged 65 and older projected to nearly double from 52 million to 95 million by 2060, we're going to be facing a large portion of our population that has multiple chronic conditions, many of which, as Rebecca talked about, are not being addressed currently during the pandemic. So what does it mean in terms of a perfect storm or a perfect opportunity? So especially as we see older consumers as the fastest growing segment of our population, and they typically have one or more chronic diseases. So what to do, and I don't presume to have all the answers, but I'd like to raise some issues for consideration as we try to work through some of these problems. So we do know that about 30% to 50% of health occurs outside of the medical system. So it does behoove us to try to pay attention to what's going on socially for people. So one of the things that I think is important to do is to leverage those community resources, the resources in the community that can help us better understand the drivers of social determinants and how we can make the most inroads in terms of addressing this. So it's important now, more now than ever, to see primary care practice as part of a system of care that involves multiple disciplines. And I think that it has to happen both on the primary care side as well as on the community side, that they have to start to embrace each other and integrate with each other, and probably in ways they never thought they would before. Then I think we also need to embrace the promise and limitations of telehealth. We did learn from the Green survey that primary care providers were often frustrated with the inability of individuals, particularly I think their older patients, to navigate. They may have had the technology, but they didn't really know how to effectively use it, or on the other hand, they may not have had access to the technology at all. So I think there's an opportunity to build on the telehealth platform and even maybe the telecall platform in terms of meeting some of those needs, but we also need to figure out other ways of reaching patients, building those trust relationships, and helping people working together to figure out how we're going to move people forward and build those trust relationships that can help us address disparities. Another related point is we have to begin to figure out and think about strategies to get people back into care. Rebecca showed us the data on people who are avoiding care, needed care because of COVID, some even risking, facing the risk of death. So we have to figure out strategies to build that trust just to get people back in the door. I think that one of the things that we can think about is access to PPE, but when we're hearing constantly on the news that PPE is not available or there's a lack of it, it doesn't help bolster trust in the population. So we need to continue to build and evolve in our knowledge of what it takes to build trust among consumers. Particularly, there's some useful tools out there that have been validated that can measure trust between patient and provider. They are not perfect tools, but some of them have a pretty good validity, and we should use those tools even while we're working to improve them. And then the fourth point I'd like to make is that from the Green study, we learned about the stress that providers are currently facing. And so I think that we need to put some emphasis in communication on encouraging providers to take care of themselves, because we need that provider base. We don't need it to go away. So this could mean solve away from provider support groups to figuring out ways where providers can get some of the psychological supports they need to be able to overcome the stress of what we're going through during the pandemic. And so this is going to mean trying to identify messages that can help them overcome denial and stigma. And I think as we go forward and we think about, should we ever face another pandemic or another crisis of this magnitude, it would be useful to embed into medical training this idea of it's okay to seek help for providers and making this a norm in the provider community. And so with that, I'll stop and let people ask questions.
Well, Linda, thank you so much. And it was worth waiting for. Your remarks were fabulous. And I think, kind of case in point, the technology doesn't always work. And think about, a virtual visit, that's perhaps goes awry. So really appreciate everybody who's joined us and your patience with our technology challenges today. Let me just tee up a couple of questions, and then we will go to all of you who have been chatting questions in and who sent questions in advance. The health inequities, the structural racism and health inequities, I think COVID has really exposed. And each of you mentioned, that primary care can be a response. I'm wondering, Anne, because you are practicing, and I think you are, in a safety net situation, how do you see what primary care may do to really try to address those inequities? What has worked, and what are some of the challenges?
Yeah, thank you so much for raising this issue. I think it's incredibly important. I mean, I think we have different responsibilities. Sometimes it's in the context of a clinical relationship, but we also have responsibilities as advocates for our patients in addressing the broader social and policy context, which enables racism to continue. So I think we can use our voices in a couple of different ways. One is advocates for social and policy change. I think we can look at our own institutions and the ways in which our institutions, if we're part of a health system or hospital, perpetuate and benefit from racism, and start to think about unpacking that. We actually just put out of Community Catalyst suggestions for actions health systems can take. And I think within the clinical encounter itself, I think training for providers is incredibly important to help us understand our own biases, whether those are at the interpersonal level or whether those are at the institutional level or at the structural level.
Thanks so much.
Can I add to that?
Yes, please. And since I can't see your face, I'm glad you're jumping in, Linda, please.
Yeah. So, the literature is rife also with information about the length of the visit and how it impacts the trust relationships between patients and physicians, and also how it impacts physicians' satisfaction in terms of being able to really relate with the patient. So I think we need to think more about what the length of those visits should be in order to try to accomplish some of the goals that we would like to accomplish, and not think of it as just increasing the cost, but thinking about it as return on the investment. If we put this investment in up front, do we get a benefit on the back end by patients, taking more action and being more involved in their care, being, more interested in taking care of themselves, et cetera. So it's something to think about.
Absolutely. This whole question of trust has been raised by each of you, and I know is a focus of work that the American Board of Internal Medicine Foundation is doing to try to understand how trust is contributing to lots of poor outcomes in healthcare, including health disparities. So it's kind of a squishy thing for the scientists among us and the clinical folks who have a scientific background to get their hands around. How do we build trust in our health system? And Linda, I'd also be interested in hearing a little bit more about the tools you're talking about to assess trust. Who would like to take that question?
Well, to be honest with you, I just read about this last night, and I'm happy to send along. I think it was a JAMA article that identified three tools that have been out there in the field to measure trust, and I think the last one came out in like the mid-90s, and I'll send that along, and just so you can share it with others. But I do think that trust piece has a lot to do with unconscious bias and making assumptions about where people are. And we have to really, really, and I don't even just mean that in a racial and ethnic context. I just think that across the board, a lot of times providers just make assumptions about what their patients know, who they are, what they're all about, and then it just really breaks down, the relationship breaks down in a lot of cases before it even gets formed, because you're making assumptions about the person and people really don't like that. And it can shut down relationships. And Anne, I turn it over to you, so.
Yeah, I mean, I think part of trust too, in order to build it, I think there has to be a willingness to think about shifting the balance of power, between clinician and patient, but also between institution and community. And I think there are ways in which that can happen, certainly at the institutional level, but I think it's important just to recognize that there is a power differential. And if you're not conscious, you don't name it and try to address it, it's very, very hard to change it. One of the things I miss doing home visits, because that forced a change in the power dynamic. If you go to someone's home, you're a guest. You ask where to sit and where do I put my bag and should I take my shoes off? And rather than a patient coming to essentially my office, right, where it's my rules and it's my domain. And that's what I think there are experiences in which clinicians and patients can really start to shift that balance of power and really build those trusting relationships, but it involves recognizing the issue.
I think also, Anne, just being willing to show some of your own humanity is an important, so I've had 2 virtual visits since all this started, and I'm sitting there going, oh, this is really stressful, and my provider's acting like it's just an everyday thing, which is totally unrealistic and totally, so it's like keeping that barrier up that says I'm not even human, I'm not even in there, I'm not in this COVID thing with you, I'm like over here somewhere. And I think just being willing to share part of your humanity is an important way of moving us towards trust.
I'm wondering, Rebecca, you wanted to jump in. Go ahead.
I'll do it quickly. The Cochrane Institute is a wonderful place that does a lot of systematic reviews of stuff, and they have a wonderful systematic review of trust instruments where they found 19. And Linda, I have no idea where they found them, but they've found 19. But I would say that trust and inequity are intimately connected, and that primary care as we know it today was actually born of the civil rights movement. It happened at the same time. It has social justice embedded in its foundation. And so we understand trust to be actually what Zora Neale Hurston talked about, which is with racial equity, which is recognizing the fullness of someone's humanity and dignity. And we can do that easily. We don't need to get overly scientific about it, and we don't need to measure it. Be respectful, be fully present. For clinicians and patients, that means when you're having a conversation, we're not seeing the email pop up in the reflection of our glasses while we're talking on the video, or we're not looking past the person while we're talking to them about what matters most. These are very simple, everyday things that we can do.
Thanks,
That's
Beck.
really true. And I just to put a finer point on that, with rise of electronic record, the provider's constantly looking at the record and never at the person. And that that's not very helpful. And so is there a way to figure out how to get your records you need without letting it interfere with that relationship?
Yes. I have heard some people say that they actually feel that a telehealth visit, their clinician is more present. I've heard on the clinician side that they actually get a window into the person's home because of the, the video. And I even heard of a psychiatrist who had a patient, show them, like it was a child, what was scary about their bedroom, because they could actually take the computer and show the psychiatrist, and it was a real aha for the psychiatrist. So there may be things about a telehealth visit, that are actually optimizing the visit. And I'm curious if you have any reflections on that, or if there's any data, Rebecca, from the Green Survey.
Sure, absolutely. So, nothing is ever black and white, right? We have a tendency with telehealth during COVID to think it has to be all telehealth or all not. And the truth is we needed it to be all telehealth when we had to shut down and shelter in place. But there are definite advantages to telehealth about certain things. And I'll leave it to Anne to talk about some of them, but some of the simple ones we can point to is people get very confused about their medications. And I don't mean they don't have all their wits about them. I mean, like anybody, you could ask me what I take and how much, and I'm not sure I could tell you. Being able to show the bottles on the screen is a big help. Being able to see something of the environment and know if it's clean or not. When people's pets walk across the screen, it creates a point of connection between two people, and that common shared purpose is what starts to build that relationship as well. The last part that I would offer is, I'm a social scientist, and we all know this. We do identity management. You act differently when you're at the doctor's office than when you're at home. It's true of anybody. The way you talk at a dining room table with your friends is not the same way you're going to talk at the dining room table with your colleagues or at a conference or with your parents. When you're on a screen, there's a blurring of that a little bit because you're at home. The identity management is different, and it's different from the clinician too. And you start to see that infecting the relationships, and it actually can be really inspiring.
And I would just, I was going to speak a little bit to the other side just to fill in, I agree with all those things that Rebecca named. I think one of the things about telehealth that I worry about is just the unequal access to it. Whether we're talking about broadband access to equipment or having the skills and training to use it. We certainly have seen some data come out that shows that, for example, among older adults, the uptake is much lower. And so, as we think about a system that relies more and more on telehealth, I think it's important to recognize that not everybody's able to participate equally for a variety of reasons.
I just want to build on that for a second, because I think this is a really important point. Insurers and payers, private and public, are both more inclined to fund video visits for telehealth than they are phone visits. And our survey shows week over week, there's 78% of the population has broadband, but that, on the other side means that 22% of people don't. That's 1 in 5. That's pretty darn big. But you know what? We know from the Pew Foundation that 96% of the population has a phone. Even the homeless and indigent have a phone, and they can get care over their phone. To limit payment of care and exclude the phone is to structurally embed the inequities that we work to mitigate in primary care.
Well, I think, we really need to really think more deeply about, I think the phone is useful for some, just circumscribing what conditions, what services you would use it for versus if that person doesn't have access, because you can't see them. You can't really just look at them and say, oh, they look malnourished, or they look sick, they just don't look right. So I think, well, maybe you could over the video. My mom doesn't have that, but I think it's important to, 25, I think it's 26% of Medicare beneficiaries don't have access to telehealth. And so the question then becomes, in my mind, do we want to broaden access, or do we want to maintain access to in-person visits so that people have both options? And one of the things that we worry about is, will this rapid shift to shore up telehealth visits result in a decline or lack of access for in-person visits for people for whom that's important? So thinking about how we strike that balance is, I don't know.
I would love, Linda, to connect that back to the trust conversation and say that payment based on modality is an issue of trust between the insurers and the clinicians, and the insurers don't trust the clinicians to do the professional and right thing. Primary care has a social contract with patients, and that includes being there when, where, and how you need it. And why don't we just trust them to know when that's appropriate as professionals? We don't govern lawyers or architects about when they're allowed to use the phone to contact their clients or when they need to see them in person and whether that's appropriate. It's a laughable concept. Why do we do that in medicine? It's because we have this really artificial disconnection between where the money comes from for the care and who receives it. So the people who pay for it directly don't actually see it or receive it, and they just don't trust it to happen the right way. And it's caused this really dysfunctional arrangement that I think we need to resolve with some serious payment reform.
Well, how would you build that trust? How would you go about that between the payer and the provider?
So I will say, since Ann said that the Green Center and PCC work together, I will say I am speaking only for myself. This is Rebecca Etz speaking based on the knowledge that I have. But what I would say is burn down fee-for-service. Fee-for-service does not help us at all. I think you got to have universal care. You got to pay people to provide primary care and then let them receive it how, when they need at the time that they need. And we have to reinvest in that trusting relationship we used to have with medicine. There was a time when we didn't monitor them at all, and that was a mistake. But right now, we have infantilized them, and we feel like unless you can tell us you picked up a pencil, we can't trust that you used a pencil to write something. It's really kind of bizarre. We need to let that go. Pay them for work, let them meet minimal standards as any other profession would, and move on. It's going to take the removal of some regulatory structures that were instituted way back to the Medicare Act that were really helpful and helped to advance healthcare in the US in a way that nothing before it did, but they now hinder. Society has changed over the last 50 years. The health needs and the financial needs of healthcare have changed over the last 50 years, and we have to have the political will to act on it, or we continue to structurally institutionalize the inequities in healthcare just as we've done in society. And I would say that's unacceptable.
Well, I thank you for that last comment, Becca. I think it brought together a lot of different threads, the racial inequities, the structural problems that we have, the payment issues, which the ideal would be to be modality agnostic. The patient and the clinician should figure out what's the best way to connect. And it will depend upon the clinical condition. I know that the Green Survey asked primary care clinicians, what's optimal, and they said, ongoing chronic condition where we understand, what the trajectory is, you can manage that virtually, not an issue. Diagnostic, we really want to see a person. Someone's having an acute event, you really want to see the person. Establishing a relationship, you want to see the person. So, I think we're going to learn a lot, and we are learning a lot over the last number of months about how to provide care in a virtual environment. We really, to your message about can we build trust so that we can all take these learnings and get rid of the regulatory and payment structures that no longer support the kind of relationships that we want, that are very rich and deep and are built on a lot of trust. So let me thank you all for joining us today, sticking through when we had a little bit of a technical issue. We've had some wonderful remarks from Rebecca, Anne, and Linda. Please join me in thanking them. We'll have this webinar up on our website in 48 hours with links to all the materials that they presented, and we're happy to continue this conversation and work with all of you. Thanks so much. Have a great afternoon, everybody.
Thank you, everyone.
Thank you. Thanks, Anne.
Oh, yeah.